Good evening, everyone. We're just waiting whilst the numbers go up. I can see them racking up. So welcome. Just get settled and we'll be with you in a couple of minutes. Hi, everyone. Okay, so I think we'll get started. Numbers are still coming up, but we will make a gentle start. So good evening and welcome to everyone for the second evening of our webinar series. It's lovely to see so many of you here with us tonight, and I can still see the numbers growing. That's brilliant. If a couple of you could just give me the thumbs up that you can hear us okay. You can do that by going to the chat at the bottom of your screen, I would think. Thank you, Anita. Thank you. Okay. Sounds clear. Thank you, Anne. Thank you, Victoria. That's lovely. Okay. So we're on our second webinar. Last week was a huge success. And I'm delighted to see so many of you with us again this evening. So to kick off, I would like to introduce Surrey Total Health to you. We are a unique consortium of 20+ consultants from almost all specialties, and we're continuing to grow. All of our consultants have full-time jobs within the NHS, and they also work privately throughout Surrey and throughout London. We understand the difficulties that our GPs are facing at the moment during the coronavirus, so this series is here to support you. Please ask any questions you have by typing them in at the bottom. A couple of you already know the score, and some of you who joined last week will fully well know what we're doing tonight. You can also raise your hands. We're very keen to have audience participation, so don't be shy. If you have any questions, we're here for you with any questions you have, so please raise your hand. We'll unmute you and you can have a chat directly with our consultants. Okay, and it's probably worth, if you do have questions and one of our consultants is in the middle in the flow of their presentation, just make a note or write them in the Q&A section, and we'll come back to you as soon as we can. So to introduce myself, I'm Susie Davis, the practice manager for Surrey Total Health. I support our consultants and run education events and workshops for our GPs. Some of you may have attended our full-day GP educational conference last September, where we were delighted to see over 100 of you. We obviously can't be running that now at the moment, so that is another reason why we are doing these online support sessions for you at this stage. Although we're not able to support you in person in surgeries, we would be delighted to support you virtually. So we do regularly do GP talks within GP surgeries, and we can mimic that by doing similarly as we're doing tonight, an online session for your GP surgery. So my email address is there on the page, and you should all have it anyway from the invitations, so please don't hesitate to get in touch. Tonight we have Mr. Ashwin Unithan, our consultant orthopaedic surgeon specialising in hip and knee replacements. He specialises in revision surgery and also complex trauma. So Mr. Ashwin Unithan is also the CEO of Surrey Total Health, and he is chairing this session this evening. Our first speaker tonight is Dr. Gautam Das, our specialist in diabetes and endocrinology and general internal medicine. Dr. Das offers regular specialist endocrinology and diabetes clinics and is responsible for admitting and caring for acutely unwell medical patients at St. Peter's Hospital. We have Zenobia Casson with us from Milan. A huge thank you to Milan for sponsoring this series of webinars. So the last week's session, tonight's, and the next three will all be sponsored by Milan. A huge thank you to you. Zenobia will give us an update on PEI and diabetes tonight. There will be time for Q&A with Zenobia and with all of our consultants at the end of each of their talks. So I'll then move on to Mr. Arshad Khaleel, who joins us tonight. He is our senior consultant orthopaedic surgeon managing disorders of the lower limb. He has an interest in disorders of the foot and ankle and routinely carries revision surgery and complex procedures. So welcome to everyone. I'm not going to wave tonight because I was waving at everyone last week, and I'm not sure if you can see them when they're not speaking, so I'm not doing that tonight. The agenda shows our order for the evening. We expect the webinar to last approximately 1 hour, so we'll be starting with a diabetes update from Dr. Das, and then Zenobia will be talking about PEI and diabetes, and then Arshad Khaleel will be talking about Charcot foot in diabetes. I will now hand over to Mr. Unithan.
Thank you, Susie. Welcome all back. Lots of familiar names. Brilliant to see all of you at 7 o'clock. We will keep sharp the time. As we know, COVID has changed a lot of things for us, and the referral pathways have changed. Diabetes is a very important topic. I'm sure you guys know more than me, and hence we come across this fixture. Now, as we are a consortium, we have got a diabetologist, we have got a specialist orthopedic surgeon who has got years of experience in this. We also got a vascular surgeon. Because of lack of time, we are not getting the vascular surgeon also. So as an MDT approach is what we prefer for this kind of complex cases. I will read out the questions as they come across on the chat and to the speakers. So it's a great privilege to introduce the first speaker. Gautam is a young, enthusiastic diabetologist who is always there to help in any of my neck of femur fractures patients. If there's a problem, he's always there to come and help and give us advice. So without no further delay, Gautam, the floor is yours.
Thank you. Thank you, Ashwin. Thank you, and to Milan for organizing this educational session. So my topic of discussion today is pancreatic insufficiency and diabetes. Of course, I'm looking at a pancreatic exocrine insufficiency and diabetes because diabetes is a pancreatic endocrine insufficiency. Interestingly, I don't know, I mean, how often you do look for symptoms of pancreatic exocrine insufficiency, because they can actually go hand when somebody has diabetes. There's a fair proportion of these patients who will probably present to us and are diagnosed because of their abdominal discomfort and symptoms. which is not necessarily a clear-cut diagnosis that we give them. And there is a need to discuss what is this pancreatic insufficiency and what's the proportion of patients who suffer from it and how to deal with it. Next slide, please. So this is a picture which shows the pancreas, which is a retroperitoneal structure, as you all know, and you can see the duct, the pancreatic duct in the middle, which drains into the duodenum. On the right side is the cut cross-section of the duodenum. Left side is the spleen, and top is the liver. Not many organs in our body acts as endocrine and exocrine, but certainly pancreas does, and that's why we are discussing this, because it means some of the data that's available in the market, it does suggest that when a person suffers from diabetes, which is an endocrine condition, they can equally suffer from exocrine complications, exocrine insufficiencies, which can be also part and parcel of diabetes. Hence, I think there is a case to discuss. Next slide, please. So I think most patients, I don't know how you get patients with pancreatic exocrine insufficiency, but most patients do start complaining of generalized upper GI symptoms. And I have seen many a times, some of them would carry a label of irritable bowel syndrome. They would carry a label of celiac disease, lactose intolerance, allergy to different food products. Some will have a label of having autonomic neuropathy. I mean, these are fair diagnoses to make when somebody has diabetes for long enough time. And if it happens that they have a poorly controlled diabetes, there is a risk that these patients can have autonomic neuropathy. But have we thought about pancreatic exocrine insufficiency if the diabetes is poorly controlled, or if this diabetes is going on for too long, like more than 10 or 15 years? You know, I don't know how often, but actually in one of the Swedish studies does say that up to 87% of our patients with diabetes can actually complain of exocrine upper GI symptoms, which part of that cohort can have exocrine insufficiency. And there is also a lovely paper from Professor Michael Cummings, which was published in Practical Diabetes 2015. And in his study, he collected data from up to just under 300 patients, like 288 patients. And a quarter of the patients actually was found to have gastrointestinal symptoms, or half have been found to have exocrine insufficiency. Next slide, please. So what is pancreatic exocrine insufficiency? So if you think of the pancreas, there is a pancreatic duct, which will have the ductal cells, which will release bicarbonate and electrolytes, and the pancreatic juices, which has a pH just above 8, you know, to keep an alkaline environment, where the pancreatic enzymes come and they get all released into the duodenum, and because of the alkaline environment, it gets all the pre-enzymes gets converted into the actual enzyme, and they become active. The group of enzymes are, you know, one are called proteolytic enzymes, so they will denature the protein that we are eating. There will be lipolytic enzymes. They will denature and break down the fat into fatty acids and other different fractions of fat. And there will be elastase, which will break down the fibers that we eat. And there will be amylases, which will also break down the carbohydrate into smaller oligosaccharides, and then it gets absorbed. You know, so these are the the enzymes that get secreted. Now, but how would a person feel if the enzymes are not good enough to digest the food? And hence the question comes: what are the symptoms of exocrine insufficiency? I mean, mainly the people would have abdominal discomfort, rumbling, bloating. A lot of people will complain of diarrhea. Steatorrhea. Steatorrhea is one of those terms, medical terms, for a high fat excretion in number 2, which is our poo. You know, so these are the symptoms. How do you diagnose? It's easy. You know, Just to make you aware that your pancreatic exocrine hormone insufficiency has to go more than 90% to have actual symptoms and to suffer from any nutritional deficiencies. And the good way to do is, I'm sure you all do it, when you get patients with chronic pancreatitis, or you get patients with pancreatectomy, you would do a pancreatic elastase to see how much of the remnant of the enzyme activity is there. And that's why it's the best way to test it. And if you find the elasticity is less than 200, which is our cutoff, above 200, we consider it to be a normal functioning pancreatic exocrine activity, then you treat it. And there will be scenarios where you will have situation where people have symptoms and they still have a elastase which is normal, and then how do you explain that, you know? And I think that is the time when patient needs attention from a secondary care gastroenterology consultant to work out, do they still have exocrine insufficiency? Because, as I said, you know, your pancreas exocrine function has to go up to 90%, you know, to the symptoms. So I don't know if there is any spectrum of this condition, you know, whether people can get subclinical pancreatic exocrine insufficiency. It's not well described in the literature, but certainly I know that if the symptoms are there and your basic checks and balances like pancreatic you know, elastase test is negative, then you can certainly ask for a secondary care gastroenterologist to help you with that. Next slide, please. I'm not sure how much you're aware of, but of course, endocrine and exocrine function of this gland called pancreas does have a relationship in between themselves. Yeah. I mean, I had a situation a couple of weeks ago in a medical ward where a gentleman has pancreatic exocrine insufficiency, first from diabetes. It's a long-standing diabetes going on for the last 20 years, now dependent on insulin, and never had a great control with diabetes. But suddenly, while being in the hospital, a strange situation happened as these patients started having hypoglycemia, and he was surprised, why am I having hypoglycemia? And I couldn't answer the question. I looked back and I couldn't work out why this man is having hypoglycemia. He was eating well, everything was going fine. But this man told me, Doc, I'm not getting my creon. So how am I going to digest my food? And how am I going to generate enough blood sugar in my blood? And hence the insulin is going and causing the hypoglycemia. So there is quite a strong relation between the exocrine and endocrine function. And I mean, you may come across patients who you're finding it difficult to manage diabetes. And it could well be that if you do look at their pancreatic exocrine function, and if you find there is a problem, and you replace the enzymes, which are the pancreatic exocrine enzymes, you may find the control can get better, actually. I mean, it's well proved, and there is a lot of evidence for that. I'm sure you know that the vagus nerve plays a big role in how our exocrine pancreatic function operates, you know, how the juices are secreted, how the enzymes are secreted. And of course, with diabetes, if it happens, a patient gets autonomic dysfunction, which means that nerves are not working, the signaling pathway doesn't work very well. They will then struggle to have the correct pH in their duodenum, because not enough bicarbonate will be secreted, not enough enzymes will be secreted. So autonomic function needs to stay right, and if the diabetes is not well controlled, it can actually impact the exocrine function. And I'm not sure if you have come across, but I do get letters from GP saying, oh, this gentleman had a very well-controlled diabetes, but suddenly, of course, things have gone all over the place. The sugars are high. So I have requested a CT abdomen just in case this patient has got some sort of tumor in the pancreas and everything has gone haywire just because of that. And I have come up with I've got a result of that CT abdomen, which revealed that the pancreas is atrophic. And I'm not sure how to explain this, you know, and the easy way to explain is diabetes can cause pancreatic atrophy. It's not just the tail of the pancreas where it's secreted. It can actually cause atrophy of the rest of the pancreas, which we don't know exact mechanism, but the hypothesis is diabetes can affect the arterioles and the arteries, and we call it diabetes angiopathy, and that can actually cause. There are many other mechanisms to explain why it can happen. Is if you have a type 1 diabetes, if you have autoimmune antibodies present, which is actually destroying the tail of the pancreas, causing the diabetes to go up, you can actually find that it can also affect the rest of the pancreas. Next slide, please. So this is a lovely paper from Professor Cummings, which was published in 2015 in Practical Diabetes, where he actually, I was telling you a few minutes back, that he looked at around 288 cases, trying to work out how many cases presented to him with GI symptoms. And you would be surprised, a quarter of the patients had GI symptoms. And then, of course, he did check their fecal elastase in these patients, and just under half of these patients were found to have exocrine insufficiency. What was recommended in this paper is it's better not to wait until you get a full-blown steatoria, which is high fatty acid, or don't wait until there is a weight loss, which are actually quite an end stage, severe pancreatic insufficiency. If you get other ways to, if you are having patients with gastrointestinal symptoms, why not looking into the fecal elastase and see what's going on there? And if you find there is exocrine insufficiency, why not replace the enzymes? And that can make a huge difference to how the person feels, probably. So it's always good to try early. Next slide, please. So what is pancreatic enzyme replacement therapy? So it's based on, it's a mixture of enzymes. So the enzymes we are talking about is the lipases, which will break down the fat into small fatty acids and different other fractions of lipid finally absorbed. And then you have the elastases, which will break down. Certainly the therapy would have mainly lipases, the amylases, so it's to break down the protein, the fat, and the glucose, which will be, and the proteases. Yeah, so that's how it works. And it's known that if patient is on pancreatic enzyme replacement therapy, actually that can stimulate the intrinsic GLP-1 secretion in the small intestine. And there is so much hoo-ha about GLP-1 analogs we are using artificially to increase insulin secretion, to sensitize the insulin, to make the diabetes control better. So actually, if you use a pancreatic enzyme replacement therapy, if it's indicated, it can actually stimulate the GLP-1, which is the intrinsic GLP-1, and can make actually the diabetes control better in some poorly controlled diabetes. So there is a case to identify it early as a part of your regular diabetes check, which we would be doing annually, including all the bloods you do in different checks and balances, looking at the eyes, the kidneys, the feet. I think there is a case to look at this exocrine aspect of the pancreas. Next slide, please. Thank you, everybody. So I will be happy to take any questions. I think I can see 2 questions already there, but I'm very happy to take any questions from any of you.
Thank you, Gautam. That was a run through on pancreatic insufficiencies. I was very surprised when you said to me before there's a new concept of using the language of diabetes, and how the primary care is so much emphasizing on not stigmatizing patients with diabetes. That's a completely new thing from my point of view. Now, I've got a few questions. Please don't hesitate. I'm going to start with the first questions, and then please ask any more questions that is required. The first question was, why is steatoria an unreliable marker to diagnose pancreatic insufficiency?
Thank you, Ashwin. This is a very good question, because steatoria is usually, I mean, it is actually a very good marker, to be honest, but because in most studies, it has been a self-reporting system. So when patients report that they have steatoria, so difficult to flush after going to the toilet, it's a sticky poo and too much fat, that's obvious to them. It seems out of the number of patients they have reported that they have steatoria, the test, when performed on the stool, it has been found a quarter has been found to be positive. Hence, 3/4 has been found to be negative. So that's why most researchers have recommended the most useful tool when you use a self-reporting system. What they are saying in most studies is the best way to work out if somebody has a pancreatic insufficiency is look into the history of this abdominal discomfort, which are vague symptoms, I know, but they can be quite reliable actually. Look at the diarrhea. Usually, Bristol chart, in the Bristol chart, any stool at a level above 5, between 5 and 7 should be classed as some form of diarrhea. Abdominal bloating, discomfort, especially after eating, and these should be used as, though I know they are quite vague because you can have these symptoms for anything and everything, but if it is happening persistently, there is a case just to do a simple test on the stool, and just look at the elastase activity rather than waiting until actually a person gets a proper steatoria.
Okay, thank you, Gautam. Briefly, I'm keeping the strict time. There's one more question at the moment. If patient has a normal elastase level and still have symptoms, how do you investigate them for pancreatic insufficiency?
Yeah, thank you, Ashwin. So I can see the question coming up on the chat box, because when are we getting a high elastase? When are we getting a low elastase actually? When your pancreatic insufficiency has almost, and hence, you have to lose the 90% of the pancreatic activity, exocrine activity, to probably creates a lack of elastin. And hence, what I'm saying is, if the patient has still the symptoms, better count on that. Rather than relying on elastase. There are other ways of testing how the pancreas is functioning, but I would not go in details, but these tests, some of the tests, I can tell you one of the tests which can actually detect the pancreatic insufficiency even when the pancreatic insufficiency has hit just above 60%, it's called a secretin test. And there are many others done usually by gastroenterologists. And I believe even if you see a elastase activity is normal and you think they have a pancreatic insufficiency, give a trial on this enzyme treatment and see what, if it's better, then you may have hit, and I think that's the way to approach. Thank you.
Thank you, Gautam. Now, diabetic foot is a very complex problem to treat, and it's a multidisciplinary team approach has to be there. And today, Arshad Khaleel is going to present a very, very important topic, which as a registrar, I have pretty much missed. Most registrars have missed once or twice with serious consequences. Over to you, Arshad.
Good evening, folks. Thank you very much, Ashwin, for the introduction. And thank you, Susie, for arranging this meeting tonight. I'm going to share my learning and experience of problems caused by diabetes to feet. I'm sure you're well aware of the scale of the problem, but locally, we look after about 400,000 patients, so about 4,000 feet. A quarter of diabetes admissions are due to foot problems. 80% of amputations are preventable. And as we will see later, these patients don't do well at all. I'm going to concentrate mainly on acute Charcot, because if we get this right, the ulcers and infections become less of a problem. In 2011, NICE suggested a multidisciplinary approach to solving these difficult problems. The idea was to bring pockets of expertise together so that we are able to share experience and learn together to improve care and outcome. At ASPH, we also had set up our MDT, and we learned very quickly that our problems was mainly late referral. We still continue to learn and share outcomes with all stakeholders. In particular, our acute Charcot experience and treatment protocols have been noted. So let's talk about this nebulous yet dreaded condition. Probably the greatest disservice done to it was an X-ray of the foot destruction in our textbook. This destruction became sine qua non for this condition. I'll share with you my early learning. I looked after this young man about a decade ago. He's already lost his fourth toe, as you'll see on the X-ray. He presented early with acute Charcot. This is his X-ray during acute Charcot. I know some of you folks don't get to see X-ray nowadays, but you'll agree this does not look like the previous X-ray I showed you of foot destruction. This is the same foot and X-ray 2 years later after the acute Charcot was successfully treated. He has a normal looking foot and wears normal shoes. Acute Charcot is a rare condition and it should be regarded as an emergency, i.e. a foot attack. In the majority, it is due to long-standing diabetes, but it can be due to other neuropathic disorders. The exact pathophysiology remains unknown, but the net result is a temporary increase in limb blood flow, resulting in increased blood flow through the skin, which produces the redness, increased blood flow through the tissues, which produces swelling, and increased blood flow in bone causes localized osteoporosis. The main lesson learned was that acute Charcot does not have to lead to foot deformity with prompt treatment. So let's look at the chronology of events in acute Charcot. In the first 2 weeks, the increased blood flow results in a swollen red foot. There is no deformity. It is usually painless, but most importantly, the patient is usually well. The history of trauma is a red herring. In the first 2 weeks, as you can see, there's a change in color and swelling due to increased blood flow to the skin and the soft tissues. This is not cellulitis, the commonest diagnosis we see made. Without treatment, over the next 2 weeks, as the patient continues to walk, they describe crunching as the localized osteoporotic bones fracture and explode, and the patient notices a deformity. Like thus, the foot is now misshapen. X-rays at this time will localize the fracture and demonstrate how deformed the foot is. At this stage, in the first 2 weeks that the deformity occurs, it is still simply correctable. However, after 2 weeks, the deformity becomes fixed. This gentleman was referred to us about a month after his symptoms. Typical Charcot destruction. The deformities are now fixed, hence a permanently misshapen foot. Untreated, if the patient continues to walk on a deformed foot, they develop ulcers. A typically fixed deformed foot with ulceration. Presentation after a month. So the clinical chronology of acute Charcot goes through 4 distinct periods of swelling, correctable deformity, fixed deformity, and ulceration. I've chosen to color the first 2, a period of about a month, in which if the correct treatment is applied, the foot can end up looking normal. So to diagnose acute Charcot, we need two clinical items. The first is swelling and redness. And the second is a demonstrable rise in skin temperature and its reversal. Currently, we can't walk anywhere without this being pointed at us. We started using this temperature gun about a decade ago to help us diagnose acute Charcot. Normally, as you'll see on your left, the shin skin temperatures are equal. The ipsilateral foot temperature is normally lower than the shin temperature because the foot is further away from the heart. In acute Charcot, as on your right, the shin temperature is higher than the contralateral shin, and the foot temperature is typically 3 degrees higher than the shin temperature, than the ipsilateral shin temperature. These findings, the temperatures you see on there, are a week ago from a colleague's dad who presented to us with an acute Charcot. Even when the disease is bilateral, the ipsilateral foot temperatures remain higher than the shin temperature. More importantly, when the temperature reversal disappears, i.e. the foot temperature is no longer higher than the shin, that usually indicates resolution of the acute Charcot. It is important to correct the blood sugars, but imaging, either X-rays or MRI scans, cause delay and are not necessary to diagnose this syndrome. The usual differentials should be considered. But painless fractures are a giveaway. Forefoot fractures with trivial injury in a patient with long-standing diabetes is probably acute Charcot. Midfoot fractures not caused by trivial injuries are acute Charcot, the most commonest presentation. And ankle fractures may go on to get acute Charcot. If a patient with long-standing diabetes and a swollen foot is comfortable and looks well, the most likely diagnosis is acute Charcot. It is very unlikely that they have a major bone or joint infection. The aim of treatment is to maintain the shape of the foot till the acute Charcot is over. And what I advise is to immediately offload the foot, i.e. non-weight bearing, and to refer to our MDT as soon as possible. You'll find this urgent referral pathway on your electronic referral system. You may choose one of either the foot clinic, the vascular, or orthopedics during and out of hours. I would suggest that please do not use these devices. They encourage the patient to weight bear, they delay presentation to us, and they do not equalize pressures correctly. There are newer versions being marketed, but they all require close follow-up and monitoring of the foot. The treatment for this condition is actually cheap, plaster of Paris, a total contact cast. It equalizes pressures and allows weight bearing. The swelling typically recedes within a week and the plaster needs changing often. The foot needs repeated X-rays and the plaster in the first month, and the patient also needs treating. I'll now share our experience of looking after acute Charcot over the last decade, and we've just finished our review. So we have looked after about 95 acute Charcots. The presentation has come down from 7 weeks to 3 weeks. 90% of our patients had diabetes, and about 1 in 10 has had a recurrence or had bilateral disease. Plaster treatment is necessary for about 5 months. 1 in 10 patients who are having plaster treatment, we are unable to maintain their foot in plaster and end up needing surgery, or they develop severe plantar ulcers. When I started operating on patients with acute Charcot, it was not the done thing. However, it doesn't raise eyebrows now. I've shown you this gentleman's X-rays previously. He presented within 2 weeks of developing acute Charcot. we started total contact cast. However, X-rays showed immediately that his foot position was not being maintained in plaster. So we elected to use more rigid external fixation to hold the foot correctly and to allow weight bearing till the acute Charcot was over. CT scans during treatment confirmed normal anatomy. And this is this gentleman, 2 years with a normal foot. We've also learned a few painful things. Sadly, 1 in 5 of our patients has passed away at a mean age of just 68. We drastically reduced major amputation rates. So I would offer, in a patient with diabetes and sudden onset swollen foot, please do not be scared of calling it acute Charcot. Request the patient not to weight bear and refer for urgent assessment and MDT treatment. Honestly, we're delighted when it's not acute Charcot, so please don't be shy. Generally, foot ulceration, as you probably know, is a mixed bag. In patients with diabetes, the key assessment is whether the foot has blood supply, i.e. the vascularity, and whether this requires addressing first. The non-vascular diabetes-associated foot ulcers are due to excessive pressure, presence of deformity, or ill-fitting footwear. The treatment options, therefore, depend on the location of the ulcer. Generally, we offload the foot for plantar ulcers. We improve the footwear for dorsal ulcers. And hindfoot ulcers are a nightmare to look after, as surgery may be necessary, which can be simple or require major reconstruction. So sometimes amputation is a more prudent option. Now, this gentleman had severe plantar ulcers. We treated him with external fixation. The metal ring that you see below the foot allows him to weight bear. The ring is attached to his tibia. So we call this contactless weight bearing. His foot actually never touches the ground, even though he's weight bearing. And this is him 6 weeks, within 6 weeks. So that is how effective offloading is. Now, I've often wondered why patients with severe and obvious deformity present late. So till I came across this work recently. This is Penfield's cortical representation of sensation and motor function on the brain. Note how small the foot impression is. And this is work from Sheffield, which suggests that brain injury leads to loss of recognition of the foot, which may perhaps explain why the foot just simply does not register in our patients. Thank you.
Arshad, brilliant talk. Thank you so much. You guys would have known that not many orthopedic surgeons can talk about the anatomy of the brain. That itself explains why Arshad stands out. Now, there are a few questions, guys. I'm sure there'll be lots of questions in it. The one question from me and one question from the audience. The question that was asked this came from a private chat. When should I? How do you convince? So the first question was, when do you refer a patient? If I'm worried about acute Charcot foot, how do I access secondary care? And the second question, I'll come to you in a second.
Thank you. Can I have just the next slide? If you have a patient with diabetes who has suddenly got a swollen foot, okay, you're talking to him, he's comfortable, and he's well, all he has is a swollen red foot. please don't hesitate in calling it acute Charcot. Okay, and on your emergency referral pathway, you will see these urgent methods of referring. You can refer to the diabetic foot clinic. We run 1 in 3 hot clinics. We run 3 hot clinics a week at the moment, I think. You can refer to the vascular team, or you can refer to us in orthopedics. And as you will notice on that slide, my colleagues have decided that the only name should be mine. I don't mind. But you can contact us through out of hours or during hours.
Thank you, Arshad. There's a very good question from Dr. Alia Mohammed, who's asking, what percentage of suspected acute Charcot foot referred to you turns out to be acute Charcots?
That's awesome. So what we've noticed now is when we started, so this is 10 years ago, almost all the feet were presenting 7 weeks from symptoms, right? So they were all at some stage of Charcot, and it was obvious. The foot had deformed, it had collapsed, there was ulceration. What we are now seeing, because of the early referral, are just swollen feet, mild swelling, there are no X-ray changes. So it becomes very difficult to diagnose. We use temperatures. The temperature reversal is our guide. And at the moment, I think just reviewing our results, we're still picking up about 80% acute Charcot before any X-ray changes happen. So I would say 2 out of the 10 referrals that we get are not acute Charcot. But we don't mind. We really, really do not mind if it's not acute Charcot, because it's such an easy conversation to have with the patient. And we are able to educate them about acute Charcot and how to recognize it.
So, Arshad, a question from me. In the current climate of the COVID, where we are trying to decrease the footfall of patients to hospital and so on and so forth. Now, to differentiate between a cellulitis and increase in temperature without blood test and all that in a patient who has other comorbidities can be difficult. Would you advise the GP practices and the doctors to have a temperature gun to measure in all patients, or patients who have swollen legs? What would your advice would be? Because I find very difficult to differentiate between the cellulitis and acute Charcot without the investigations.
Yeah. So the key, what I'm trying to encourage people is to think of this condition as a syndrome. So syndromes have constellation of signs and symptoms. We are able to pick syndromes without any investigation. So what I would suggest to you is that you have a patient whose diabetes control, who's got long-standing diabetes. So you know this patient, and all they noticed is that suddenly their foot has gone red and it has swollen up. Okay, and if it's unilateral, it's even more convincing. So if you have a patient with a unilateral swollen red foot, which has come on suddenly, now the patients may distract you with a red herring of I had a little a small trape or a small injury, but there's nothing broken in the skin. I would still suggest that that is acute Charcot. Now, if you're comfortable using the temperature gun, which is actually not difficult, you make sure that the foot and the shin is uncovered for about 4 or 5 minutes, and then you compare the shin temperatures. Now, in acute Charcot, where there is swelling, you would notice the shin temperatures go up compared to the other side. But more importantly, the foot temperature goes up by 3 degrees than the ipsilateral shin temperature. 3 degrees is a pretty significant number. And this happens because in acute Charcot, there is tremendous increase in blood flow in the skin. So I'm not aware of, because we have patients who have who have diabetes and fractures, and we have looked at that group of patients. In fact, we're writing that up because we have I think last year alone we had about 40 odd patients who presented to us with ankle fractures who had diabetes, but not acute Charcot. So we measured their temperatures and we did not see this reversal of temperature.
Okay, brilliant.
I hope that answers it.
Yeah, Arshad, there are lots of questions. A final question, Susie, if I may. Susie keeps on looking at the time. There are certain. I sometimes I have worked in a GP practice for my sins, which I can understand how difficult it can be for you guys. They have certain companies do advocate using walking boots. Who recommend for diabetic ulcers.
Yeah.
Now, you have categorically said not to use a boot. Now, is it for Charcot's or for a diabetic foot ulcer, which is not, there's not a lot of difference there.
Yeah. Okay, so if you have a patient who has no ulcers, let's give you two distinct scenarios. So you have a patient who had a normal foot a week ago. He now wakes up and he has a swollen red foot. Now, initially, they will not present to you. They'll call you a few days later, unless they're educated, okay, or they have been informed to look after their feet. And they call you and they tell you that, Doc, I've woken up and I have a red swollen foot and it's not getting better. Okay. What I would, the key thing in what we've noticed in this group of patients is to get their foot off the ground and into a contact cast, because what happens is that the swelling causes localized pressure, and remember, the bone has increased blood flow, so it becomes osteoporotic, and the middle of the foot, okay, the middle of the foot starts to soften and collapse. Now, the air cast boot, or its different varieties, encourage the patient to weight bear, and everybody thinks they are being treated. So the patient doesn't access secondary care on time. They continue to walk, and the pressure changes in the foot are such that the midfoot tends to collapse. So the traditional air cast boots, we've had serious problems with. So what I would suggest is more important to get the patient not weight bearing than to put them in an air cast boot. Now, let's take another scenario where you have a patient with an ulcer. Now, this ulcer, if you know, is because of a deformed foot. Okay. So the last thing you want to do is stick him in an air cast boot. Right? Because if you put him in an air cast boot, that ulcer is not being treated. That's the wrong treatment for the ulcer. So as I suggested, if you have ulcers in patients on the top of the foot, i.e. on the dorsum of the foot, they are due to poor footwear. And if they have pressures on the bottom of the foot, i.e. on the plantar aspect, they are due to high pressures. Okay, the foot has deformed and they're getting high pressures, and we need to change their footwear. So even in that circumstance, air cast boot is probably not the answer. Now, there are lots of things being sold to us and they are being used by the podiatrist, but what happens is that the podiatrist then sees the patient at least twice or 3 times a week. Right?
Okay, I got you.
That's the point. Then the foot needs to be monitored.
Arshad, a good question from Dr. Emma. If you do not have a temperature gun, how do you differentiate from cellulitis to Charcot?
Okay, so again, go back to that syndrome. So keep it simple. If you have a patient who is well and who has woken up suddenly, no major history of injury, and their foot has swollen up, and the shin is red and the foot is red, just call it acute Charcot. Don't hesitate. You do not need a temperature gun, especially if you have a patient with long-standing diabetes. Now, monofilaments and 2-point discrimination, and these are even more complex. So the temperature gun is a much easier thing to do. But if you don't have that, all you need in this syndrome, as I said, are 2 things, and you've already got one of them. You've got a patient with sudden onset swollen red foot.
Excellent. Thank you, Arshad. There are a few more questions, guys. We on the Very Total Health page, you have a button which Susie will let you know, which you can refer as patients, ask questions. But going on, the 3 important things I have learned is, to summarize from an orthopedic point of view, is about steatoria, the 3 T's from synovium, and if you have a Charcot's foot, refer, and non-weight bear. Thank you, everybody. I'll hand it over to Susie.
Okay, guys. Thank you for some brilliant presentations this evening, and so lovely to see so many of you. Some really good questions. Lovely to see Victoria and Kumbi and Kala, and thank you so much, guys, for hanging on. I know we're a couple of minutes later, so yeah, the referral link is very simple to follow. If you take a note of this, we will be recording these videos, and I will be sending links through to you at the end of this, and we will also be sending you, you're very welcome, so I'll be sending certificates of attendance for tonight's webinar. In 2 weeks' time, we have breast cancer with Dr. Manish, and so we'll wrap it up there, and we will see you in 2 weeks' time. Thank you, guys.
Thank you, everybody. Thank you.
Thank you.